This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is Dr. Deepak Megur. He is a 65-year-old gentleman who has this mature white cataract. And apart from this, we can see a small corneal scar here. It's actually an adherent glaucoma. The iris is attached to it underneath it. History reveals that he has sustained a penetrating injury few months back. We have posted this case for surgery, so I would want all of you to just pause the case here, take a pen and a paper, and try to write down the answers to the following questions. Number 1, what complexities do you expect in this case? And number 2, how are we going to deal with those complexities? Okay, I have assumed that you've written down the complexities or challenges which you're going to encounter in this traumatic cataract, and let me address this how I was thinking so that you can then verify. The first thing would be, now this is a case of a penetrating injury. The first thing we'd always want to know is that whether the anterior capsule is ruptured. Number 2, whether the posterior capsule is ruptured. Number 3, is there a retained intraocular foreign body? So in this picture, there is a faint hint of a line which looks to be a calcified, or this line is probably a breached anterior capsule. I'm not sure, but I'm expecting this line to be a ruptured anterior capsule simply because it is coinciding with the point of injury on the cornea. So that is where I expect the anterior capsule also to be torn. And if it has gone beyond, then maybe even the posterior capsule also would have been torn. So we really don't know what is the situation, but at least from the outside it looks like the penetrating injury has gone through the cornea into the anterior capsule as well, and there is this iris which is sticking onto the corneal injury, causing this adherent glaucoma. Okay, now what investigation is mandatory in this patient is to get a B scan done to rule out any intraocular foreign body and other posterior segment pathology like vitreous opacities, vitreous hemorrhage, or retinal detachment. So in this case, we did a B scan, and B scan shows few vitreous opacities in the membranes, but nothing alarming. Now, assuming that we have a breached anterior capsule and a question mark posterior capsular tear, which we don't know, how do we plan surgery in this patient? The first thing would be, I would like to give a peribulbar block in this patient because I expect the surgery to go on for a longer time. I aim to perform the anterior capsular rhexis in whatever segment it is possible, so that in the event of a posterior capsular tear, I still have adequate anterior capsular support to attempt to place a posterior chamber lens in the sulcus. So that was my initial goal. And because I'm not sure about an underlying posterior capsular tear, in this case, I would consciously choose manual small incision cataract surgery, simply because in the event of a pre-existing posterior capsular tear, there is always a risk of the nucleus dropping down. So that's the reason why I have chosen a much more safer option. The plan is to remove the nucleus manually and then assess the situation. If the posterior capsule is intact, then obviously my plan is to place the lens in the bag itself. And obviously, because there is a potential for a pre-existing posterior capsular tear as well, needless to say, I am ready with my anterior vitrectomy tools. So let's begin the surgery. I begin my surgery by making 2 side port incisions. Air bubble is put. Dye is injected under an air bubble from the left side port as there is adherent glaucoma near the right side port. The ideal way would have been to deal with the adherent glaucoma first, release the synechia, and then dilate the pupil and then stain it. But I couldn't do that way because if I put OVD to release the synechia, then the subsequent staining of the anterior capsule would not be great. So that's the reason why I'm trying to stain the capsule, whatever is exposed now currently. And then now I'm pushing in OVD and to deal with the synechia. I'm using micro scissors to cut off the iris which is sticking onto the back of the cornea. And now the anterior synechia is released and the iris is free from its attachment to the cornea. The conjunctival flap is raised. The scleral groove is created. A 6.5 mm frown-shaped scleral incision is created. A sclerocorneal tunnel is then fashioned. So using a sharp keratome, the inner lip is now perforated with the bevel up 2.8 keratome, and the corneal end of the sclerocorneal tunnel is now enlarged on lateral sides. So now we've made the opening good enough for an easier explantation of the nucleus. A time to perform the rhexis. I'm using cohesive OED to maintain a deep chamber. So let me pause the video for a moment here. Can you look at this white line? This is probably the area where the anticapsule was split or is perforated. So where would you want to start the rhexis now? So if you thought about it, maybe just write it down in a paper, and now I can talk about what I did. So the basic idea is I would want to avoid the area on my right side to initiate the rhexis, because I know that the capsule is already compromised there. So I'd like to begin the rhexis from my left side, make a puncture, raise a flap, and then try to create a sort of a circular opening at least on my left side, because in the worst case scenario I would like to still have some support of the capsule to place in a posterior chamber lens. But as soon as I reach the area of trauma, the anticapsule is quite thickened there and it's uncontrolled, so I couldn't go around it. So I ended up having a slightly smaller opening in the right hand side. So that area of the capsule is thickened and it is calcified, it's irregular. So I go in with my micro scissors to make a snip in the capsule. So I try to raise a flap and then somehow tear it. But I'm not sure about the integrity of this part of the capsule. I have a feeling that this capsule is perforated on the right side through and through. And I'm avoiding any hydrodissection because in a case of a discontinuous rhexis and a potential pre-existing PC tear, hydrodissection can do more harm than good. It can bloat the posterior capsule. There's a reason I avoided it. I just nudged it, and I'm going to use 2 Sinskuk to wheel the nucleus out of the bag. The nucleus is easily wheeled out of the bag, and then I'm going to use a phaco sandwich technique to capture the nucleus in between these two instruments and then pull it out. The epinucleus is expressed out. Now is the time to check for the presence of vitreous and the status of the posterior capsule. I'm going to use diluted triamcinolone acetate, and as it is gently washed off, you can see a strand of vitreous coming towards the main incision. At the same time, I can also note there is no red glow. It is quite dark, and because there's a bluish tinge, I can assume that it is because of the trypan blue which has entered through and through. So there was a pre-existing, the perforated posterior capsule or a zonular weakness on the right side, which gave access for the dye to get into the vitreous cavity. So time to begin the vitrectomy. The sclerocorneal tunnel is a self-sealing incision, so that's one good thing. I don't have to suture it. So I'm going to use the 2 side ports, one for the irrigation and one for the cutter to do my anterior vitrectomy. So the cutter goes in and the anterior vitrectomy is done. It takes a while for me to do the anterior vitrectomy, maybe about 7 minutes. Now, how do I decide the end point of anterior vitrectomy? So whenever I see that the corneal folds start to appear, that's indirect evidence that vitreous or OVD in the vicinity of the antechamber and below it is not there, and this is my clue to say that the anterior vitrectomy should be enough. This is the end point which I follow. Once I'm convinced that there is no more vitreous and most of the lens matter is out, now is the time to put the lens. Now in this case, I'm not so sure about this anterocapsular support which I have. Obviously there is a very large posterior capsular defect. So at this point, my thought of putting the posterior chamber lens in the sulcus is not there. So I'm now convinced that there's not enough capsular support to attempt a posterior chamber lens, so I've decided to go in with a iris claw lens. And in these cases, I would prefer to do an iridectomy. So here, I prefer to do the iridectomy using the IA cut mode in the vitrectomy machine. So we start with the irrigation. Foot position 2 would be aspiration. Foot position 3 would be cut. And the aspiration flow rate we would be keeping around 14, and the vacuum would be around 100. and the cut would be the least possible setting in the machine. If it is 100, keep it 100 or 50. In this case, we have kept it as 100, and I just go in and press with one stroke. Initially, we engage the iris and one cut. So we go through and through. So we have a nice little iridectomy in the inferior quadrant. I chose the inferior quadrant simply because the visibility was better there compared to the superior area. That's the only idea. Now, a few tips for putting the iris claw lens here. This is an iris claw lens which is made by Excel Optics company, and I don't have any financial interest. I find these are much more predictable. The design is slightly different. These are much more smaller than the iris claw lens made by other companies. These are also referred as artisan lenses in the Western countries. This is not a planned side port incision for the iris claw lens because we hadn't planned it. So whatever the side ports which I had initially created for my surgery, the same ports I'm going to use. Both the haptics are aligned at the horizontal meridian. This is the Clayman forceps which I use to hold the lens. The lens is held not in the center but in the paracentral area, which is almost nearing the edge of the optic, and then the end of the forceps which is holding the lens is usually coincides with the level of the cleavage which we have in the haptics. So that gives me an indirect hint that where is the potential cleavage in this haptic so that I can engage my iris there. That's the reason I prefer to hold my forceps at this particular position. So another point which I would like to share here is that before introducing the forceps to hold the lens, my side port instrument, which is a 26G hydrodissection cannula, has already gone into the side port so that I don't have to struggle when I want to enclavate to enter into the eye. So that's the reason why I've pre-entered my cannula first and then the forceps goes in. And the lens is actually pushed anteriorly now against the iris, and a single tap will do, and you can see that the iris has got enclaved in the haptic of the iris claw lens. And this dimpling of what we can see is an evidence that enough iris tissue has got enclaved in the haptic of the lens. The same process is being repeated in the other side. Again, please note the position of the forceps as it is being held. It is nearer the edge of the optic, and the position of the tip of the forceps is exactly coincides with the notch which is there on the haptic. The haptic is slid under the iris, and then the haptics are pushed up against the iris. And now I'm going to introduce the cannula and I'm going to stroke the iris over the haptic at the right point so that we have a nice enclavation. So sufficient amount of tissue is enclaved even in the first attempt itself, so I don't have to redo it. I'm sure that it is sticking on well. And now is the time to remove the OVD which has been pumped in. So whenever I have done the enclavation already, in this situation I prefer to go in with my cutter and the irrigation through the main incision itself. And simply because when you go through a closed chamber technique, there is a sudden buildup of pressure and there could be a deepening of the chamber. That's the reason why I prefer to go in. And because the vitrectomy has already been done, there is a lesser risk of inducing more prolapse of the vitreous. So at this stage, going through the main wound is alright and is probably preferable. Once I'm certain that most of the OVD which is behind and in front of the lens is removed, time to close. Now, although this is a self-sealing incision, I'm going to still use a single suture just to combat the against-the-rule astigmatism which would have induced by this incision. The conjunctiva is closed using a thermal cautery, and that's it, the case is done. And these are the third day pictures, and the patient is doing fine. Hope you found this helpful, and thank you for watching.